We're going to go ahead and get started. I'm Mike Pitt. I'm representing the Global Health track, and thank you for coming to this rounds. I'm going to introduce our speaker today, Dr. Claudia Munoz. Dr. Claudia Munoz-Zanzi is an associate professor of epidemiology in the Division of Epidemiology and Community Health in the School of Public Health at the University of Minnesota. She obtained a doctorate in veterinary medicine in Chile and a PhD in epidemiology from the University of California. She's an infectious disease epidemiologist, and her current research programs are focused on the epidemiology and social ecology of zoonotic and emerging infectious diseases, including leptospirosis, toxoplasmosis, hantavirus, and more recently, tick-borne diseases. Her work is taking place all over the world in Chile, Mexico, Panama, Indonesia, and the U.S., and has been funded by the NIH, NSF, and other sources. She's actively been involved in training dozens of undergraduates, MPH, and PhD students, and teaches in the core epidemiology curriculum. She's an elected member of the Executive Committee of the International Leptospirosis Society and a member of the Steering Committee of Global Leptospirosis Environmental Action Network. And today she'll be talking about the unrecognized global burden of leptospirosis, advances, challenges, and diagnosis and control. Dr. Munoz, thank you.
So let's try the microphone. We're very, very happy to be here. It's a wonderful room. Despite the fact that you're all spread out in the room, I'm hoping that we're going to make this something more conversational. So feel free to stop me. I think I have enough time. Not that many slides, so we can hopefully have a good discussion going on. So thanks for the introduction. I'm supposed to show this. So my goal, for this session is to increase your awareness about the burden, the importance of leptospirosis, and understand some of the challenges that had to do with detection, and also become familiar with what we're trying to do with WHO in terms of using a One Health approach for control. I'm also supposed to show this, but I have nothing to report. So I want to start with this. Leptospirosis. We all, for people working in this area, we joked that it's not really a joke, that leptospirosis is neglected from the list of neglected diseases. And now it's nowhere to be found there. So because of that, we have all the challenges on trying to obtain funding, increase awareness. So as a result of that, WHO, while there was a time probably where there was no other epidemic going on, they decided, okay, let's look at leptospirosis. We really need to figure out, is that, how important it is relative to other diseases. So they started an initiative to estimate global burden. They put together a group of experts, and they worked on an actual report where they calculated the burden. The challenge was that there's not a lot of information or good quality information to inform that modeling work. But they came up with a report that was published recently that states that there is approximately 1 million cases globally per year. Now, the caveat is that because of the source of the data, a lot of was hospital-based. You have to look at that number as we're really talking about sick people. Not a lot of the mild flu-like, that maybe didn't make it into those counts. So you can think that the actual number is much higher than that. They predicted from that 60,000 deaths per year. And in terms of economic cost, they came up with 2.9 million. And that's this, if you're familiar with the literature, I can tell you that it's very similar to cholera and other emergent infectious diseases. So the main message is that it is out there. It's very common, and but we're doing very little about it. So just wanted to give you an overview of the understanding of the transmission cycle. And this is So obviously it's a zoonosis, and it can be in pretty much every mammal, in wildlife and domestic. So it maintains, within each one of those species, and also there is cross-species transmission. It's shed in the urine, and that's how the environment is contaminated. We become infected through from what we understand, most of the time is from indirect contacts through a contaminated environment, but also there are instances of direct transmission, mostly related to occupational contact, farmers, contact with blood or fluids of animals who happen to be with septicemia at that time. Of all of these, we mostly talk about rodents as a very important source of infection, but there's a lot of gaps in our understanding of this problem. So we know that most of the infections, I would say 80%, is from mild to flu-like. So most people don't even know that that's what they have. It's self-limiting, so it never gets diagnosed. Even though they spend days, at home, they're still sick, it never gets diagnosed. And at 20 to 20%, it can be very severe. The typical will be the Wells disease. But the point is that we see the tip of the iceberg, and because of the broad spectrum of possible clinical manifestations. So other thing to emphasize in terms of transmission, and understand the challenges, is that, yes, we have this picture that I show you that have all the different potential hosts. We could think of it as a rural environment with close contact with life and animals. We can think of rural villages where maybe there are fewer livestock, but still have the rodents. And then we have the urban, where we mostly have rodents and dogs. So each one of these settings obviously has different implications for sources of infection and what to do. But not only that, I don't know if I don't have the tongue. Yeah, I forgot to put the little thing in my computer, so I'll just have to do this. But no, this is not the only challenge, trying to understand the different transmission cycles. But a rural village in a temperate climate is very different from a rural village in the tropics. So the implications and what we can do about it are very different. So now you have these three different settings, that and the transmission changes depending on the climate, the local socio-ecological conditions. So the answer to these questions is not really it's not one for all. What we have been learning over the years is that we really need to customize it to the different conditions. So it will work now?
This one should work. If you want, I'll just take this. Yeah. This one should work, sorry. Yeah, I guess not. Sorry, you might just have to come back. Sorry about that.
Yeah. I don't think that either worked. Okay, so no. So now, from this same work that was done to estimate the burden, with the limited data that was available, they came up with a global map of incidence. So the main message here is to emphasize that, it is widespread with clearly higher risk areas than others. This is Southeast Asia definitely is up there in terms of risk, but some specific areas in other places. With incidents that can go from 100 per 100,000 in the red spots to 0 to 3 in the lighter yellow color. So it is definitely all out there in terms of incidents. So those are the cases that we see sporadic. The large number of the burden comes from these sporadic cases that trickling down, in the high-risk seasons. But we also have outbreaks. And most of the time we hear about leptospirosis when there's, in the local news in these various countries, even here in the US, is when there is an outbreak. So this is work that is in preparation. It's a systematic review of outbreaks worldwide that are in the published literature. And what you can see here is similar to the incidence map, that on top of that sort of incidence endemic levels of infection, we will see outbreaks. And these are, remember, these are the ones that they actually were published. So, there is the bias associated with that. But things to point out, again, we are talking about Southeast Asia. A lot of reports in Europe, mainly because there's a lot of people working on leptospirosis in Europe. And also the reporting bias in there. A lot of in Cuba, lots of work of leptospirosis in Cuba and Central America. Lots of reports from the US. These are actual outbreaks. The definition of outbreak, changed depending on where you were. In the US, if two people are epidemiologically related to the same source of infection, so it's a time and space correlation, we call it that an outbreak. Yeah? But that's very different from an outbreak, in a highly endemic area. A lot of these outbreaks are occupational, recreational, like the triathlons, all those events, and obviously a lot that we hear in Hawaii. So I wanted to give you an example of a typical outbreak that I was using this as an example of a very well worked out outbreak investigation that was done in Peru. And the story is that these are children who they had, in summer, they have an activity over the weekend. So all these children from this one school went to swim in this place where there was two areas. One was a canal, and the other one was more of like this creek type of thing, for swimming. And so that was, after that fun day, and the end of December, then the first cases show up at the clinic, and then we'll see, where they were able to come up with this very nice epidemic curve. So we will see, the incubation period, everything that we can understand from this curve. So, they diagnosed these first cases. Then, and once they realized that that's what's happening, they, the trained epidemiologists at the clinic did an actual case control study. A lot of the reports that we see, a lot of the reports that we found in this systematic review, yes, to report the cases, and a very nice description of the cases. But without a control group, there is really not much you can say in terms of exposure. So what they did here is that they actually went to the same children, and they tried to find the control. So they were exposed to the same setting, but they were not infected. And what they came up with is that a significant factor for infection was, here's your Spanish, contact with the acequias, this creek, that had dogs. So that's one of the highest odds ratios over here. And the other one was swimming in the same creek. Now the other place that was nearby, it was the canal, was not. So two things, they were able to distinguish, the canal versus the creek as a source of infection through this analysis, and, also the presence of dogs. There was also an additional investigation of actually testing the dogs, and they did fine, and there was also a correlation in the strains that were identified. So it was basically, it was the dogs that were contaminating this specific place. So this is an example of a typical outbreak that will make it into the news. And so everybody that's trying to do something in response to the outbreak, and then we kind of forget about it, and then until the next one. Now, talking about cases, this is another example that I picked to show you the challenges, with diagnosis as we start getting into that topic. This is from Cuba. Cuba, has an amazing leptospirosis program. Because of the way their healthcare works, they're able to really have good registries, they have good laboratories, and they are able to analyze and get samples and enroll people in all sorts of things. So this is a study that was done. They looked at children, 2,000 children from 2 hospitals. And they actually picked up children that had 2 samples, the acute and the convalescent sample. and also blindly, just that was the inclusion criteria. And they test for leptospirosis, and they found 83 confirmed cases based on seroconversion. Only 11 of those came into the hospital with a presumptive diagnosis of leptospirosis. So basically, this is the spectrum of symptoms that they saw: fever, headaches, myalgia, arthralgia, vomits, and so like nothing. Nothing. This is the standard of leptospirosis. It's nothing that descriptive. So laboratory confirmation is critical, if you want to make a diagnosis. And then what they found in these children is that, just based on history, is that swimming, direct contact with animals, and contact with animal waste was the potential source of infection. So now we have this problem, of all these very generic symptoms, and so this the problem of trying to differentiate leptospirosis from other diseases. So I will say in the last 3 years, as malaria in many places is going down, because of effective interventions, and also because they are trying to get away, move away from treating without diagnosing malaria. So now the rapid tests are more available, so people are identifying, okay, these are actual malaria cases, and they get treated. But then many of those people who initially thought they were malaria, or dengue even, now they know they're not. But why are they then? So because of that, people are trying to look into these other causes of undifferentiated febrile illness. And this is a summary that was put together showing that, out of those in the different parts of the world, with different criteria, but, you will see that leptospirosis is consistently there, and how much obviously depends on where you are. This is a more specific example of children, not children, but less than 20-year-olds, but these are the different age groups in Cambodia. And what they did is that it's a community-based study where they look for cases of febrile illness, and they actually collected pair samples, and they tested leptospirosis on the ones that were negative, for dengue, Japanese encephalitis, chikungunya. And so you can see this number over here is the number that, based on seroconversion, was leptospirosis over here, around 4% in the different groups. These over here are the ones that have antibodies, just in the first sample. It goes, obviously, that tells you that 40% of these children already have been exposed at this age, and it goes up with age, which is what we see normally with antibodies, over time. So basically, what we're saying is that there is a lot of infection in these children at a very early age, and the 4% is the ones that were actually with a recent infection at that time. So, in terms of diagnosis, so the typical diagnosis will be, obviously, we have a suspicion based on clinical symptoms. They're very fever plus all the more generic symptoms, and the actual inclusion criteria for here, it really varies. Different countries have different ways of doing that. The trend in the last year is that it's becoming more and more inclusive, as people are realizing that, we also need to add meningitis, we also need to add this. It used to be very like Weil's disease. Now it's definitely growing in terms of the symptoms that need to be considered as a suspect. There is more, the history is important, and the interpretation of all of that put together really depends on where you are. If it's a highly endemic area versus a low endemic area, how much evidence you put together in order to call that person a suspect. In terms of differentials, it's like pretty much anything, you can think of, it's going to be there. So that's why laboratory work is so important. And I'm going way slow. So diagnosis is, for confirmation, it used to be culture. And we require to have culture in order to be confirmed. Luckily, we're moving away from that. Why? Because it's extremely hard to culture, and it takes 4 months, to call a sample positive or negative. I mean, positive, once it's positive, yes, but negative, you have to wait 4 months. So obviously, it was only really done for purposes of trying to isolate. It doesn't have anything to do with clinical care. So now that we know with the use of PCR, things are moving ahead, and laboratories, finally are considering PCR as a confirmed case. Then we have MIT as a serology, microagglutination test. That's also considered the gold standard. And if it's in a high endemic area, you have an acute sample with more than with a titer of 1 to 400 or higher, it can be considered recent. Better, if you can actually show seroconversion. But most of the time, especially if people recover, it's very hard to get a second sample. So those cases are never confirmed, and they never make it into the registries, even in countries where reporting is mandatory. Because without a second sample, it's not confirmed. So we have a general problem of diagnosis and under-reporting. So the main message here in terms of diagnosis, that I want to give you today is the importance of time. So diagnosis was not only like, we all are familiar with sensitivity and specificity and all of that, but the point is that in leptospirosis, it's not only diagnosis, but early diagnosis. It has been shown that, it can be treated, but the sooner, the better. So in order to do that, we need to identify these cases as early as possible, within the first week, hopefully. And so what we understand is that, this is sensitivity of MAT and ELISAs. And basically, the main message is to say that look at the difference and sensitivity, as this is days post-onset. The very first days, these are antibodies. Obviously, they're very low. It's too early. So you're not going to get anywhere with just testing the samples, even with MIT. And then you can get to 100% later on. But the point here is that this is the window of time we're trying to diagnose these cases, where sensitivity, to detect antibodies is very low. But, here is the, it's sort of representing this is the time where you can actually find it in the blood, and so it's going to be the first week, then it goes down, it's more spotty. So this is the chance to use PCR to detect it, as a way to diagnose in the first week, and, in the different sources. So we have this issue of, trying to detect as early as possible. Antibodies, the sensitivity for antibody detection is very low. We have the chance to, and it's not, and it's not confirmation. We have the chance to confirm using PCR, but we have this very specific window of time where that can happen. So this is an example of a diagram for confirmation. This is using the Netherlands. And I'll show you because it's, it's not a high endemic area. But the main message here is to say that they have, their inclusion of PCR and ELISA. So they have, and also they're based on history. So they have yes to history of potential infection, no. Then based on when we are. These are the days of onset, from less than 10 or more than 10, or a no. Then you apply the different tests. If it's PCR, great, we confirm. If it's serology, if it's MIT, the interpretation of serology depends on the actual titer. And so then go through the difference. I'm not going to go through the whole thing, but they go through the different venues. And even if there is no history, they still apply the same criteria, but with a higher cutoff. They want to make sure that they're not, including people who may not be infected. So the cutoff here is different from here, based on the history. So now we're kind of moving towards this scheme, of using PCR and using antibody detection, either with ELISA or with rapid test. That are more effective. Now the issue that we encounter is the quality of the work, the kits that are out there that are not being validated, and that each one of these, ideally, we want an algorithm like this for every laboratory, that is diagnosing cases. So in order to understand this a little bit better, I'm leading a working group where we're using mathematical modeling to try to answer some questions related to transmission, the epidemiology, leptospirosis, but also about early detection and prediction models. And I'm not going to go through this, but basically what we're trying to do here is answer questions such as, if we have the different combinations of possible tests, what are the optimal in terms of detecting early, reducing days in the hospital, reducing morbidity, and in a cost-effective way. So you can answer questions like that using this mathematical modeling approach. So when we have some results, hopefully I'll be able to update you on that. So all of this is work in progress. Now, so what are some of the barriers to diagnosis and treatment? So as I said, it is treatable, just standard antibiotics. But the most benefit is when it's given early, and we have the issue of misdiagnosis, and we're trying to push laboratories to use PCR. I was in a meeting recently in Rio, with representatives of the Minister of Health of the different countries, in the region, talking about exactly the same thing. And their answer was like, PCR is too expensive. We're going to stick to MAT, which you need the actual lab cultures in the lab, and it's super complicated. We're going to stick to MAT or maybe ELISA because PCR is too expensive. That's the response. So hopefully now we're trying to show some evidence that investment is worth it, because we're going to be able to see gains in the number of people that we're going to be able to diagnose and treat early. So capacity building is very important. And also you will see more and more point-of-care diagnostics, and the problem with that is great. The idea is great. The problem is that it's validation. So we're trying to this initiative with WHO, trying to get protocols for validation, reference samples, that can be shared for different groups. And I think that I'm convinced that between PCR and rapid test, we can definitely start making ways on improving this. So the last few things I wanted to talk about was a little bit about control. So there are limited options. And if you think of, understand the transmission cycles, you said, why? To prevent infection in the first place. It's because a lot has to do with social and cultural determinants. It's where people live, what people do. And there are the rodents, there are the animals, the way they interact with this potential host. So a lot of this has to do with behavioral changes, which is, for lepto and for many other diseases, is one of the most challenging things. Try to people understand, make them change the way they think about rodents and the way they live and sanitation. And this just to give you some overall numbers of, this is a little study about awareness and practices. And these are numbers of people who do rodent extermination, proper trash disposal, just the basic, glove wearing if you are a farmer. And, numbers are just really, really low. So then, yes, we can bombard them with education programs. But if there is not a really change in the mindset, it's definitely a stumbling block. So as I said, this is not only about individuals changing their way of thinking, the way they protect themselves, but a lot of those has to do with like cities having to do sanitation projects, trash removal. It's very expensive. And I can tell you the number of times that we wanted to bring the press, to one of our meetings, to increase awareness. And they said, no, because the city is going to get mad because we're talking about rodents and trash. It's a very, very delicate topic, and then politics get involved, so it is very challenging. We have, as I was explaining now, we had still a lot of gaps in our understanding of the transmission. Until now, even though we kind of know that environment is very, very important, that's how we think that most people become infected in the first place. Believe it or not, nobody has looked at the environment in the first place. Now, mainly because of culture and the challenges in lab diagnosis, lab detection. So now with PCR, we're starting to look at the presence of pathogenic lepto in the environment. And this is a study that I did in one of my sites. And it's basically just PCR positive samples, from the actual pre-domestic environment, like puddles and things that where the children are playing in the mud and all of that. And so we can see the presence of contamination. And now we're moving into trying to sequence and genotype. So we start, linking that with the genotype of the bacteria in the animals, the genotype of the clinical cases, and start, creating this ideal, surveillance system where we can actually inform practices based on evidence. But this is all theoretical because people are always fighting. The animal people don't want to share data with the, human people, and so you'll see some of those meetings become very interesting. Because of time, it's until 1:15, right? Yes. So the last thing I wanted to mention about understanding the ecology is that it is just really puzzling. It's a little bit. What we have been understanding is that the ecology is extremely local. That means that what we understand in this community over here, is that, maybe it's these animals are contaminating the environment, people are doing this and that, and you go to a community, looks exactly the same, but over here, and things may be totally different. And this happens again and again, when we discuss with other collaborators and other people. So there are some, things that if you want to make recommendations, it may apply to one system but not to the other. So there's a lot of research that still needs to be done, in this aspect. And over down here, we're talking about vaccines. Vaccine, there is no vaccine. Well, let me rephrase that. There are human vaccines. There is one in France that is being administered to sewer workers, and there is in Cuba. At this same meeting in Rio that I was talking about, there was finally, we're keep inviting the people from Cuba, and finally somebody showed up at that one, is, we don't have the actual information, but, the graphs is showing that they are applying their own vaccine, they develop it, and they can see the surveillance, after vaccination, how much they have been able to drop incidence, after vaccine. And the vaccine is administered, it is mandatory, they have, the way of doing things, but the point is that there is a vaccine, and the potential, it's out there. No, there are not even like companies trying to think of the planning stages of one. Even the one in France is just really from France. It's not really getting anywhere else. Challenges are protection. It's very serovirus specific. So pretty much like, you have to make a vaccine that's appropriate for every place. So you have to be on top of the surveillance, figure out what are the circulating isolates, And you either have, it's either, which is really what's happening right now in the animal vaccines, is that they have to really be, have the same reservoirs that are circulating. So you keep adding more. And so for humans, it will have to be the same thing. And if the experience of the animal vaccine is the same, is that they require frequent boosters. So obviously, it is not really a hot thing for companies to start to put efforts and money to develop. So I wanted to add with this idea of working together, in an interdisciplinary fashion to try to do something about this. So probably you have heard about this One Health, And I like this definition from WHO because it puts everything in perspective. We want to reduce the public and animal health burden in a way that's collaborative, cross-sectoral efforts of human, animal, and environmental health in a multidisciplinary approach that considers the complexities of the ecosystem where the humans and animals coexist. So that's sort of, to me, it really says what we're trying to do here because of the type of the complex system that leptospirosis is. And this is not only for research, but also for clinical care, for control, and for policy. My vision, and also the way I try to sell this to funding agencies, okay, you don't care about lepto, but, there are many common drivers, for these diseases. So what we need to know is like, if I do rodent control, it's not going to impact lepto, but it's also going to impact this and this and this and that. So it's really about integrated community-based control programs, where leptospirosis just happens to be one of them. So the way, using this approach, we can go not only to like pathogen-specific surveillance and efforts, but it's really a multi-agent approach. And then combine human and animal interventions and evaluation at the community level, of what those potential cost-effective control programs are. So to me, and how do we get to this multi-agent? Is and starting the conversation about not only diagnosing, just one pathogen at a time, but diagnosing, the whole series of pathogens that are in that community, in a cost-effective way. Now we, with sequencing and all these new methods that we can do that is not only pathogen-specific, but it really covers the entire spectrum of pathogens that also have common drivers of transmission. So I wanted to end, just to show you what we're doing, what GLEAN is all about. This is the Global Leptospirosis Environmental Action Network. This is a follow-up of that burden of disease initiative that was done by WHO. So it's really being led by WHO and this Health and Climate Foundation. And it has been years, working with little, not little, but not enough progress, mainly because every time we're all like ready to do something, then there's an Ebola and then there's a Zika, and so things get really, really slowed down from the WHO perspective. But we are a core of experts that have been getting together to look at things in a very multidisciplinary way. Definitely multi-institutions, multiple countries working together. And the core of what we do, we separated to explain, and there's different pillars. I'm the coordinator of the project pillar, but I'm also working on detection. So it's sort of, we're also working together and trying to improve, prediction of the epidemiology part, control programs to prevent infection, diagnosis, and then interventions for outbreaks and things like that. So I just wanted to acknowledge and collaborators, people who have been talking about this for a long time from different places and institutions. And I think that's my last slide. So happy to answer any questions.
study you did where you looked at puddles and containers, and that was in Peru.
That was in Chile.
What would that look like in a rural area in the United States? Would you expect zeros, or what kind of numbers would you expect, or has that been done?
No, it is there. I'm convinced. In Chile, this is southern Chile. It's cold. It's not tropical. You know, it's southern Chile. It's very rural, green. You know, we have a season in the winter that's cold, but it's there. You know, I was actually surprised it was there in the first place. You know, so the big question is, you know, as you know, it can survive in the environment for a long time under optimal conditions. So I found it there. Is it lepto has been there through the winter, or this is leptospirosis that was shed recently? This is work that we're doing right now, not only to detect using PCR, but also to have a marker if live lepto or not. So now we're moving ahead, you know, with questions like that to try to get a better proxy for contamination. So going back to your question of what will we find here is, you know, it's like every other household, they're all poor living conditions, right? So it's the trash, the debris, so, you know, the dogs walking around, you know, that kind of environment. But I'm sure that we will definitely find that in similar places, especially in, you know, more of the Floridas, the temperate, the humid places, and even here in Minnesota, just in the right time. But again, it has to do with that, it's the living conditions. You know, you need the rodents. Somebody's putting the lepto there. It's urine, after all. So it is the rodents, the dogs, and livestock, and the wildlife. Yeah, sure.
You have been